sorry, Madam Chair. YouTube Live took its sweet time loading, but we are now, we're all ready to go.
Okay, great, thank you. Good morning, everybody. This is the budget hearing for the state agency referencing the Department of Children and Families that we will have this morning. So I'm ready to call this meeting to order. Good morning, Commissioner. How are you?
Good morning again, Senator Austin. Good morning, Rep Walker, Rep Gilchrist, and good morning to all of the other members of the Appropriations Committee. I'm not sure who's on Zoom. You have the written copy of our testimony. Would you prefer that I read it, or we just jump right into
Let's
discussion?
jump right into discussion because all of us can read the testimony. I don't think we really need that. So if you just want to make a couple highlights on things that you have of note, that would be great.
Certainly. You will notice that our agency budget mitigates the behavioral health challenges exacerbated by the pandemic, further implementation of the Family First Prevention Services Act and other prevention related activities, and adjusting the department's lens of service provision more so in the upstream prevention area, mitigating instances where DCF involvement with families it happens sooner than coming into care. With me this morning, I have the department CFO, Melanie Sparks, and various members of the department who are subject matter experts should there be a need for more detail on a particular issue.
Thank you very much, Commissioner. So first off, just a technical question. The agency has 2,974 in the requested by the agency, and the governor recommended 2,943. How many people do you actually have working for you right now that are on the payroll right now?
We have,
And you have to identify yourself the first time you speak as a.
sorry, Senator Melanie Sparks, DCF CFO. We have 2,000, our vacancies are 324. So filled right now, we have, let me give you 1 second.
2649.
2,649 full-time permanent filled vacant positions
That are filled.
that are filled.
Thank you. And the 324, where do they stand relative to being hired? Do you have them in the queue? Are they posted? Are you going to sign a few onto into DCF working experience? Where are they?
All of the above. We can get back to you in work group with the specifics, but all 324 of those vacancies are in the current recruitment process, whether it's approvals or posting or interviews or onboarding.
Okay, great. And so when the governor's recommended is some 31 less than what you have there, that would eliminate 31 positions that you already have currently in the queue to be hired.
No, ma'am, those 31 are actually filled. They're IT positions. The 31 reduction is just a transfer over to DAS bids.
Well, I'm very glad that we would want to consolidate IT when we couldn't even run the building a couple of days ago. You don't need to say anything. That was a editorial comment that I shouldn't have said. I did. But I did. And then I see that you're consolidating the Middletown office into the Meriden office. Commissioner, can you tell me what the rationale is for that?
Certainly. We were looking at the impact of the CBAC telework agreement and the percentage of staff who are physically in our DCF offices. We overlaid that with the offices that were on a month-to-month lease and looking to reduce the state's footprint just based on the number of staff that are physically in a building and the transition to kind of doing work remotely.
So my question on that is relative to children or families that might see on a walk-in basis. How is that going to impact people who live in the Middletown area? What is the length of time that they would have to drive or take public transport to?
You got the breakdown of.
And if you don't have it now, you could bring it to the committee meeting.
Oh, but that's, yeah. We'll talk about some of the other numbers.
So we're not actually proposing any service reductions as a part of this consolidation. Our contracted services will stay where they are. Our in-home services will stay where they are in Middletown. It's just moving the staff from Middletown into the Meriden office. So minimal increased driving time for our staff. And then as far as our in-office visits, with the implementation of the quality parenting centers last year, much of our supervised visitation is provided at the QPCs in the community, not in the office. And we were fairly successful in rerouting bus routes to Meriden. So we now have buses that go directly into the Meriden office.
So a client would not have to have increased transportation time. It would be more the staff that would have
Yeah,
increased
we anticipate
transportation time.
minimal impact to any client.
And how many people that do you have that are in amongst your work staff that do telework?
So the CBAC agreement called for 80% telework for the majority of our staff that do in-person visits and the casework and all of the typical the majority of DCF work. I have expected that the leadership has 50%. So we scaled that back a bit to make sure that there was leadership coverage everywhere in all of our divisions and in all of our offices.
So it's 80% of the individual employees time frame, not 80% of the staff, but 80% of the
Yes.
individual employees.
Correct.
And 50% of managerial employees time. So an individual managerial employee
Half.
can do 50% of their time on telework.
Yes.
And pardon me for not necessarily understanding all of that. Does that, do you have a way to tally somebody's work from home? Is there like if I sign on to my computer and I don't have and I turn off my camera, you're not going to know if I'm here or not here.
So if you recall, we also implemented the Kronos timekeeping system, which requires staff to indicate telework or regular or in-office work.
So I could write down, I could say to my constituents, I'm on the computer doing work, but how does anybody know if they don't see my picture up there? You know, because a lot of times if you don't have good bandwidth, you turn off your camera.
So I also want to make the distinction between telework and remote or virtual work. All of the work that is expected of my staff is still in person. So, you know, whether a meeting takes place over Teams is different than the expectation of what they do still has to be in person. The telework agreement allows for them to do that, to leave from their home, to go to a home visit, leave from their home to go to court, or, you know, to not have to come to an area office in order to check in per se. So, you know, I think what's
Okay.
happened is that, you know, the conflation of remote work and telework, which are distinctly different. The expectation is that they are still doing in-person work.
Okay, so that you're not saying, I just want to make sure I understand this because this has been something I get questioned all the time. Why are, you know, 100% of state employees are now working from home? And I say, no, that's not necessarily true. So if I have to go to a client's home
Yes.
to inspect that home environment,
Mhm.
that is done in person. That
It
is
is.
not done. It's not like I can go, that I have the person sign in on a computer and I am taking their word for it that the house is clean and safe and there's no, you know, for lack of a, you know, it's not like food is all over the place or the place hasn't been cleaned in a month. Don't go to my house. And exactly. But-
The expectation of in-person work is for everyone except for our 24/7 locations that don't have a telework option. Obviously, they are in the building. So our Caroline, actually, they do have some telework availability now with our new phone system. But in our facilities, obviously, they are there 24/7. And those that are afforded teleworks, the expectation is that they are conducting in-person work in community and with families.
Okay, thank you for that.
Mhm.
And then I see that we're suspending the private residential treatment facilities rate increases, and what is the rationale for that?
Talk about PRTF.
We'll have to get back to you with the specifics on the rationale. I have those numbers. I just don't have them with me.
Okay, if you could bring them to when we have the workshops, that would be great. Thank you, Matt. Representative Walker.
Me.
You.
Good morning, everybody.
Good morning.
Morning. We're, it's taking us a little time to get ourselves focused because we've had a little bit of a week and it'll be a long day today. So I hope you guys tune in and watch because we'll be here for several hours. Thank you for coming before us. I'm going to start with the reduction in your numbers for ARPA.
Mhm.
You have a reduction of 6 million this year and about 32 million next year. Can you tell me where those reductions are?
For ARPA,
Uh-huh.
we don't have any reductions for ARPA. As we use the ARPA funding, it expires because it's federal. Are you
Uh-huh.
talking about our board and care reductions?
Uh-huh. Well, okay, then maybe I'm reading it wrong, but it says, well, you look for the American Rescue Plan and in the budget for 22, it was 15, and in 23, it was 40 million, and now you have 9 million and 8 million for these years. So what did you conclude? What did you complete, or did you complete utilizing those dollars?
So that's all this.
Yeah.
So fully implemented was the Child First expansion, which was the pivot from the OEC reprocurement. The intensive transition care management has been fully implemented. Fully implemented was 24/7 statewide access to mobile crisis. Fully implemented is the urban trauma initiative. Partially implemented are the Racial Justice Provider Institute, the Subacute Crisis Center, which crisis stabilization, which we can talk about. Also partially implemented is the peer-to-peer care coordination with DEMIS. When there was several other fully implemented pieces from ARPA, which is a resource guide on development and translation, peer-to-peer training program, respite for non-DCF families, and seed money for Waterbury IOP through DSS. Those things are fully implemented.
Okay, could you send that to us for the work group so that we can know? I noticed the only one that annualized or continued really in your budget was pediatric mobile crisis unit
Thus far.
thus far. So the others have already, there's no other funding in the budget to address any of the items that you mentioned there.
So most of the ARPA initiatives that we put forward that had to do with children's behavioral health, we were really cautious that there were things that could be sustained beyond ARPA or that at some point would be picked up through Medicaid. Because of the structural nature of the urgent crisis centers and the subacute stabilization, those are the two, I think, biggest impact service types to this money. Since they have not been fully implemented yet, it would be premature of us to think about the sustainability of those because they have not even been operational yet.
Okay. Well, I'd like to get the details so that then we can go a little further. I also noticed that you have a very large reduction in board and care for children in foster care. Can you explain why it's about $10 million, if I'm not mistaken?
That is a reduction commensurate with the lower number of children coming into care. We have had about a 30% reduction in kids coming into care since 2019 in our administration. We've watched that number quite closely. We've watched the repeat maltreatment and reentry into care also to make sure that, it's just not children coming into care, but they're remaining safely at home. We also recognize that reduction is not a full reflection of that 30%, but rather still leaves us somewhat of a cushion for fluctuations in caseload. So we believe that that is reflective of a steady decline in our child and placement numbers.
Okay, so what I'd like to have is, let's have a chart of foster care for the last 5 years so that we could see the decline that you're experiencing in that. And in that same vein, I also noticed that there's some reductions in congregate care services.
Mhm.
Can you explain a little bit of it so that we can understand it? And then I think that's a bigger conversation. I'd like to, again, 5 years, I'd like to see where the shifts are going. I think we talked about this in JJPOC, but I did not connect that with the dollars that I'm seeing in there. And quite honestly, a lot of my colleagues and I, we're concerned. We're concerned about what we're seeing with the spike in issues with our children under DCF care and some of the problems that are happening. So we want to get a little bit more detail about what that is. And do you have what are you using for quality assurance now? Do you have a quality assurance department that is now taking over since you got out of 1F?
Sure.
How are you overseeing to make sure that things are being followed up?
We are. I would like to start with just a comment related to congregate care. You know,
Yeah.
about a decade ago, a third of our children that were in care were in congregate settings, and we had about 360 plus children in out-of-state care. Very expensive residential placements far away from their families. Today, there are 5 children in out-of-state care who have complex medical needs that can't be met in state. That steady reduction of children in congregate settings has hovered and I think sustained between 6 and 8% of the overall total number of CIP, even with the shift and downward trend. So smaller N of all the kids in care and sustained smaller percentage of those children that are in congregate settings. The reductions that you see are reflective of vacancies and the utility of congregate placements, which, you know, largely go about 60% unfilled. So any reduction that we've shown in congregate care, which we'll bring to the work group to give you a little bit more granular detail on that, has been reflective of utilization. What I think happens in the larger discourse is that children whose needs need to be met on the juvenile justice side are often conflated with children in DCF custody alone, and that we, you know, continue to be at that table to come up with options and strategies to be able to address children's needs that are on the JJ side or delinquency side that may not necessarily have Child Protective Services involvement.
Okay, so that would be part of the conversation also, because a lot, I'm hearing conflict in some of those things. So I'd like to know about that. And going back to the quality.
Oh, sorry.
Excuse me. Tell me, what are you guys doing for quality assurance and how are you evaluating it?
So our Bureau of Strategic Planning worked directly with our court monitor on the last several years of our involvement in the consent decree. And so they worked, if you recall, most of the measures that the court monitor looked at with us were 6 months ago. What we were really striving for is to be able to look at our data in real time, to be able to help with performance management and to give our area office directors data on their specific offices. So each of our offices have QI social workers that are embedded in their offices that can give them their data to help understand the flow of cases, the percentage of kids in congregate, the percentage of children in relative care, or any of those variables that they may need at a moment's notice, as opposed to looking 6 months in arrears. And so we developed those processes and procedures while we were still under the consent decree to satisfy that once the decree and the monitor was gone, that we could sustain our quality assurance measures.
Okay, so you have a very formal process.
We do.
It would be good to see that formal process so that we understand it, because everybody seems to use that as an issue. And my final question is on Solnet.
Mhm.
Well, you have 324 vacancies. That's huge.
It is.
That's huge. And I don't know how you manage with the avoid that much. So, so that, we need to understand how are you dealing with that, but
Mhm.
Solnet, Senator Austin and I went there a few months ago, and it has not gotten better.
Right.
And those are very fragile circumstances. So what is your vacancy in Solnet right now?
So I thank you for asking that question, because when you came to visit, we were quite confident that we would be able to open up the beds that we had closed because of exactly what you're talking about, just the need to make sure that we were operating the facility safely. Because of the healthcare workforce crisis, we were impacted more so there than any other place in the department in terms of the recruitment and retention of nursing staff to be able to safely reopen those beds. So if you recall, when you all made the visit, we thought by the end of the summer, a few months would go by and we would be able to hire enough staff to be able to do that. The summer came and went, the fall came and went, and we just did not get the amount of traction that we needed. We participated in a calling all nurses hiring campaign that was targeted to try to get more nurses to not only Solnitz, but the other state-run facilities. And that didn't yield the type of response that we thought it would. So GAS and OPM recently had a subcommittee, a working group of which we were a part of, to come up with strategies to be able to address and opening up those beds. And so the current vacancy is 68. Am I reading that appropriately? With 13 head nurse vacancies, 4 LPNs, 10 nurse vacancies, and 3 per diem. This doesn't include an authorized 40 new positions of LPNs, because one of the strategies was that, we may be able to recruit more LPNs than we can RNs. And so those 40 positions are now in the queue, hopefully to jar that staffing crisis into being able to reopen those beds. But we share your concern.
Yeah, I really, and I will say, I did hear that the CSU system is trying to become more aggressive in trying to find. I think we have to look at some incentives and things like that. And when we were there, we heard a lot of people were concerned about the pensions and the shifts. Those are the two that we heard more than anything. So I think that's important. Okay, I'll come back.
Yeah, no, but we hear you. And one of the strategies, I'm sorry, before we move on to the next topic, one of the strategies related to the shifts that the workers were talking about in terms of, that most nurses would want to have the type of shift they would have in other entities that aren't public, like a public facility. In order to be able to do that, we'd have to have the staffing filled in order to be able to shift to those preferred shift differentials.
Yeah.
Right? So.
Okay,
That's one of the strategies.
Thank you, Madam.
Thank you. Up next is Representative Nuccio, followed by Senator Lesser.
Good morning. How are
Good
you?
morning.
I have a few questions. Some of them kind of on the same topic, but not really. For the reduction in the private residential treatment facility, I'm wondering, this is probably just more for my edification, but on page 18, we have the reduction, and then on page 20, we have the exact number as a positive. Is this because it's statutorily required, it's put in and then it's removed from a policy?
Yes, and we'll bring those numbers to the working group
Okay,
specifically.
all right. The next question I have is in relation to, you had mentioned the juvenile justice cases that you have, and I know you've got money in your budget here for the YSBs and the JRBs. And I've heard from organizations in my area that the JRBs, there's no teeth, right? There's nothing, like, if people decide to just not go, they
Yeah.
just don't go until we keep cycling these same kids through until we get to the point where they are either an adult or they commit a felony. So because this money is in your area, what's your oversight of that? And is this enough to actually, what is DCF's role if people are not complying with the JRBs or the YSB information?
So that, it's a loaded question that we have been actively involved in with the POC. We no longer have oversight of juvenile justice. However, we do have responsibility for JRBs and YSBs. Now, the youth service bureaus are tricky because many of them are run and financed by municipalities, and the percentage of what we support in the youth services bureau sometimes doesn't offer the incentive for the Youth Services Bureau to comply with the expectations of what they should be delivering. And so we've been working really hard with the JJPOC to think about ways of understanding that system a lot differently than what we do right now. As far as juvenile review boards, that is a program on the diversion side of things, work closely with our CSSD partners to think about ways to make sure that the same kids are not falling deeper into the system, because it's intended to be able to address first-time offenders or children that may be getting in trouble at school or in community. Again, our role in that is administrative, and we did recently pay for a landscape analysis that did not yield the information and recommendations that we had hoped it would. And we continue to look at both the youth services bureaus and the juvenile review boards in terms of their efficacy. But it's housed in our transitional youth division within our department. But we can bring you back some additional information if you'd like.
And say CSSD, just so people listening can know what that means. Commissioner,
I'm sorry, the Court Support Services Division on the Judicial Branch
and the JJPOC,
is Juvenile Justice Policy Oversight Committee.
thank you. Not for those that are here, but for those that are online. Go ahead, Representative.
So you mentioned that you guys did a study and it didn't yield the results that you hoped it would. Can you give us, maybe in the work group, what did that study reveal? And I'm just looking at, there's not a lot of money in
Right.
here for either of these two line items. And I know this is just a portion of it, but my problem is having a portion here, a portion there, a portion there, and no oversight means that we're continuing to let these kids slip through without the needed supports that they need, so they don't progress further down the line of criminal activity, right? Going from skipping school to something that's going to end you up in jail, right?
We certainly share the concern about making sure that the diversion is truly diversion. And, I think as we build out our prevention continuum on the child protection side, to me, children are children. And so we have to kind of view the needs of all kids in that way. So we share your concern.
So I guess then what I need to know from you is, how do we make this more robust? How do we make it more effective? And what does that mean from a budgetary perspective?
Mhm.
Because I'm not a person of going halfway,
Yeah.
right? I think halfway is just a waste of 100% of money. So if we can figure out how to structure this in a way that's going to give you guys what you need to actually be intervention on this, then, I'm interested in having that conversation.
So certainly let's talk further. Thank you.
I appreciate that. And then the annualize the funding for Family First Prevention Services Act program. This is extending the ability if I'm reading it correctly, it's extending the ability for these dollars, and it's in conjunction with federal grant money. Is that correct?
So Family First Prevention Treatment Act was initiated as the opportunity for states to be able to get reimbursed for prevention related activities. And so the first step in that was to develop a prevention plan that identified what the candidate for foster care would look like in our state. And so we successfully did that. We submitted the prevention plan, and now we are at the point of implementation of Family First. And so the question related to where we are along that phase, you can kind of talk about that.
So we were given $1.5 million last fiscal year. How that worked out in our budget was about 1.1 million in FY '23 to be annualized to the 1.5. So the 377,000 you're looking at is the annualization to get us to that 1.5. That 1.5 million was given to us to expand Families First eligible community services, specifically our functional family therapy programs and our multi-systemic therapy programs. The FFT programs have been implemented. I believe they're hiring right now. MST, that is still in the works. Once those are implemented, we can begin to claim to the federal government for the services provided to kids in those programs. And in turn, the federal government reimburses the state of Connecticut, not DCF, the state of Connecticut, for the services.
So it reimbursed all of the costs, the total 1.5 million. I'm assuming the 1.5 million is mainly staffing.
It's mainly staffing because these are in-home services. And our estimation on that 1.5, the return of that would be about 1.7. So it's about a $200,000 gain to the state.
Okay, but we're not receiving that money yet because the programs are not
Correct.
up and running. Okay.
Is it?
If you could bring in any information about that program, I'd be interested in learning a little bit more about it, especially the therapy pieces of it, I think are really important.
Mhm.
And the last question that I have, because I see a hook in the corner of my eye, the last question that I have is on the American Rescue Plan Act, the extension of the Pediatric Mobile Crisis Intervention Services. This is an extension, so I'm wondering if you have results or numbers for us for how often we're utilizing this, where it's being utilized, if it's in like certain areas of the state. And kind of what's the cost benefit analysis of $8.6 million?
We can certainly bring you the data related to what we've learned since the expansion.
I would appreciate that. Thank you very much.
Thank you. Up next is Senator Lesser.
Thank you, Madam Chair, and good to see you, Commissioner.
Good morning, Senator.
Good morning. I just wanted to first follow up on Representative Walker's question. When you were talking about numbers for Solnet, was that the whole facility, or were you just talking about the Solnet South location that we visited?
So south and the hospital. That is just the hospital.
So
That's just the hospital.
So could you get us the numbers for the whole?
We have that, sure.
Okay, great. And are you seeking or have you been granted by that subcommittee additional flexibility on HR for filling those vacancies? It seems like the Solnet vacancies are really a critical issue for, a mission critical issue for DCF, and want to make sure that you can move as expeditiously as possible. Is that something that you're considering or have been granted?
Appreciate that. We have prioritized it within our HR, and you've kind of asked a question that is one that we have been looking to try to balance ourselves, that, if we put all of our attention on the Solnet side to get those positions hired and recruited and onboarded, at some point, sometimes you don't have the manpower to do the same on the social worker and child protection side. And we neither can afford to have a delay in kind of keeping and making sure that we have staffing to fulfill our mandate. But OPM and DAS have committed to helping us open those beds, which also will include some additional support and human resources to be able to get those positions filled.
Okay. And also on the subject of behavioral health, my understanding is that there's currently a wait list of over 400 families for intensive in-home child and adolescent psychiatric services. Can you list all of the wait lists that DCF currently has?
We can certainly bring you information to the work session on what we know about wait lists and whether or not that is the same number that we see based on what the providers are sharing with us. But I will tell you that much of the wait list is associated with our provider struggle to also fill positions that they have vacant.
And maybe that's the answer to my next question, but I see the reduction in funding, the baseline funding for the out-of-home care accounts in the budget. And I wanted to know, if we're seeing persistent wait lists, why would we be reducing that, and what's the cause of that?
So you're looking at our board and care accounts, board and care foster, board and care congregate. Those accounts are restricted to use for not necessarily for services to kids, but the actual cost of caring for kids out of home, foster parent stipends, clothing, things like that. So those accounts are directly correlated to our caseload trends of children coming into care.
And thank you. I'll try to be respectful of the subcommittee's time and hand it over. But one question about the proposed elimination of the Middletown site that Senator Austin asked about. I understand that the analysis is based on the current shift to telework, but I also know from what you've just said that one of the issues across the entire agency is persistent understaffing. If DCF is able to fill the vacancies that you've already been appropriated, can you still use the Meriden location? Have you looked at that? What's your baseline assumption for staffing? And also, are you assuming that the telework agreement in CVAC continues in perpetuity? If that were to go away, would you also have an issue?
Yeah, I appreciate the thought on that. Our hiring and staffing concerns that we have in the nursing allocations and for our SOLNet don't necessarily translate to hiring or staffing issues in our area offices. So the decision related to consolidation of offices was not based on staffing vacancies, but rather the physical presence in an office of the staff that we do have. I don't believe, is Middletown one of the offices that we have staffing concerns with? It's not. So that was not part of the equation to consolidate in that particular issue. We don't foresee an end to the telework agreement. So we were thinking long-term because, right now our footprint is if you go into the area offices, there aren't people there quite a bit because of that agreement.
And that's a location that you share with DSS, is that?
That is one of the co-located areas of, I think DSS is on the other side of that physical building.
And have you coordinated, you anticipating that DSS is going to assume the DCF space? I don't know what planning has gone into this.
We haven't had any, I've talked about the issue in our Health and Human Services kind of meetings with each other, but I don't believe there's any other plans from any of the other state agencies to consolidate with any of their offices, but they don't have a one-to-one. There are several of DCF offices that share with DSS, but not all of them. If that answers the question.
Yeah. And I was encouraged by your report that will have minimal impact on the clients that DCF serves. If you could share that analysis with the committee, that would be very helpful.
Certainly.
Thank you very much.
Thank you, Senator. Up next is Representative Gilchrist, followed by Representative Dathan.
Thank you, Madam Chair. So good to see you, Commissioner,
Good to see
and
you
your
too.
team. My first question has to do with the direct service contracts and the adjusted funding. If I'm reading this correctly, you're able to you've done a review and you're reducing in these lines because there's less than a 65% utilization and there's a no current services wait list. My question, so as you all know, I chair the Trafficking Council and I do quite a bit of work with survivors of child sexual abuse. And I'm hearing from them, that there's just an incredible demand for services. So what I'm trying to get at is, are we lacking the services? And so that's why there's no current services wait list, because we need to actually create the services.
Yeah.
Is there a way to get at that?
Yeah, there is. And, I think that one of the things that we are attempting to do with a process of review of our service types is to make sure that the services we have meet the needs of the people of Connecticut. And we have lots of capacity in the existing services because they may not necessarily match the need. So any of the reductions that you see are a result of sustained vacancy of not using slots for particular services. And the reduction still allowed for a cushion for some of what we saw as unused capacity. And so I think it's our collective responsibility to then see what is it that where are the gaps that, which service types could emerge from all of this, so we can make sure that there's a better fit between needs and services and not have just capacity where we know that we have wait lists in other areas.
Would you be able to bring to the working group any information you've pulled together on service gaps, in
Mhm.
particular as it relates to the child abuse and neglect intervention?
Mhm.
Thank you.
Sure.
And then my second and final question builds off of what Representative Walker was speaking to with regards to the foster family placement versus the congregate care.
Mhm.
When you're looking at quality measures, do you track the number of placements per child?
We do.
Would you be able to bring that information?
We sure can.
Because what I'm hearing from the field is, you know, are there negative outcomes, which I would think there are, of a child being placed repeatedly?
There are.
And maybe there are certain populations who would do better in congregate care. And so just trying to figure that piece out.
We value family. We will definitely bring the detail of that to the working session. We absolutely support a child, if a child does have to come into care, that first placement is their last placement. And that first placement, we currently have about 50% of the children under the age of 18 with relatives or someone that they know, which tend to be more stable placements in terms of that, what you just referenced in terms of bouncing and bouncing and bouncing, which we know is just not good for kids. What we also recognize is that along with the numbers of placements that children have, the length of stay in congregate settings also has a detrimental impact on kids. So, kind of thinking simultaneously about how quickly a child can be supported in a family, even when they have a congregate placement to meet a clinical need, is just kind of that balance. So we've recently also re-procured a therapeutic foster care model and are really trying to see if the implementation of that gets to the question that you've asked.
Thank you. Thank you all.
Thank you, Representative Dathan, followed by Representative Exum.
Thank you so much. Nice to see you,
Good morning,
Commissioner, and thank you
Representative.
for bringing your team. They've been such wonderful supports for so many in our state. Just wanted to kind of follow up with the possible reductions in services with less than a 65% utilization. Can you please highlight in the working group, you don't have to talk about it today, which services might be eliminated, how are you going to manage to ensure that nobody loses services? And then who are the providers for those services, in particular, which nonprofits? And are you working with those nonprofits to make sure that they kind of rethink their services? So if you could bring that to the working group, that would be great.
We certainly can.
Great.
And we meet regularly with the trade associations for the providers that contract with us, and many of them have shifted their service models and business types to be able to meet the needs of our kids and families. So we will definitely bring you the details on that.
Okay. And I was listening in on my car when you first kicked off, and I just wanted to make sure that to the working group that you provide the cost and caseload trends
Yes.
for TFA, SAGA, and Husky B. We do have some information from like 18, 19, and 20, but I'm just kind of curious where we got to be in 22 and 23. And if you could also provide an answer on why those caseload changes keep decreasing over that year-on-year period.
Those are Department of Social Services programs, not DCF.
Oh, I am so sorry. I was looking at the wrong sheet.
I got nervous.
Yeah.
But I didn't have an answer.
About that. No, I was kind of thinking overall trends of programs that we have within DCF, and I might not have the names to hand.
Okay.
But if you could share that with me. In particular, I'm really focusing on children with intellectual and developmental disabilities, and how we are looking at those sort of caseloads, how we're managing transition services, and understanding any sort of wait lists that have to go along with those.
Thank you. We can certainly bring that to the working group.
And I'm sure somebody else already asked about the lapses, but I didn't hear it. but would love to get that understanding as well. What's lapsed in the agency.
That's under surplus retention. Okay, do you want to know about that? or-
Thank you, Madam Chair.
Oh, you're talking about us, our lapses. Okay, yeah, we can bring that.
We can
Thank you.
bring that to
Thank you.
Thank you. Representative Exum.
Thank you so much, Madam Chair. Good morning. It's
Good
good to see
morning,
you,
Dr.
Commissioner, and good to see
you
the
too.
team. I just have a question around the expansion around the pediatric mobile crisis intervention services. And I just really would like to know how the staffing, since it is such an issue, I know this is very much workforce related and very frustrating. So how is the staffing going for this initiative?
Mhm. So because we didn't have to build mobile crisis from the ground, it was a service type that we had. It was truly an expansion. And I believe that that one does not show the wait lists, and like it doesn't. And we measure things like the time it takes to get to a call. We measure things like the handoff to a community-based provider, and we can bring those details to the working group to give you some insights as to where that particular service type is doing well across the state and where we might have some problems.
And this is the one in which the provider goes into the home
Mhm.
versus the urgent crisis centers that are
Correct.
coming on board. Where would they be represented in this?
So they are represented under ARPA initiatives. So I can take just a second to talk about the two of the major service types that were added to the behavioral health continuum as a result of the investment that we got in the last session. So the urgent crisis centers are mostly implemented. We got the funding of 13.5 million to be able to create that 23-hour crisis center. There are a total of 4 programs, and they are all in the hiring process of staff right now, and look to be able to accept kids by April 1st. There's one that I think might go sooner than April 1st. The challenge that we've had is that other level of care that was the subacute crisis stabilization. We put an RFP out for those, and we really only got one response. And so we went back to some of the providers that we know might have the competencies to be able to handle that level of care. And that one is taking a little bit longer to implement. And, you know, what we had talked about when we had those discussions around children's behavioral health last session was that, you know, backups at any level were as a result of the full continuum. And so we put these models forward as a way to address the flow of children through the system. So you're spot on to ask the question related to emergency mobile psych as being kind of the lightest touch when a family might be in crisis, that a clinician can come out all the way through to, you know, if a child needs hospitalization for a psychiatric issue. So these particular levels of care are being stood up. The urgent crisis centers will come to fruition much sooner than the subacute because of interest in the provider community and being able to deliver.
That's good to hear. And will there be 4 of the urgent care centers?
So urgent crisis centers are 4, and then subacute currently we are working, well, we have 1 and we're trying to get 3 more.
Trying to get 3 more. And if we could, I know I could ask a lot of questions around this, and I know that I'm not allowed to. So when you come to the subcommittee, if we could.
You are totally right.
Thank you, Tammy.
I got Tammy's back on.
So if we could just talk about this just a bit more when you come
We
back
certainly
to the
can.
subcommittee. Thank you so much. Good
Certainly
to see
can.
you all.
Thank you. You too.
Thank you. And I want to tack off of a question that Senator Lesser brought up. And it's relative to the providers. And you said that the wait list is relative to some of your providers. Are you seeing an increased decline in the number of providers you have, or decline in the number of people or young people that they can support? And would the reason for that be because of the amount of dollars the state pays to make sure that they can provide salaries for those people, if you know?
I will say that what we're hearing from our providers is this challenge of hiring the right level staff to be able to deliver the types of services that our kids need. Even in the surplus retention of when, the providers were struggling to fill those vacancies, we want to talk about that so I don't mess it up. But it was being able to have them retain those dollars for recruitment efforts to be able to bring their staffing up so they can fill those vacancies. But you want to talk about the
I can give
technical
you some
piece of that?
numbers on surplus retention. So the legislation that was passed that allows providers to request retention and reinvestment of their surpluses was passed with the language that says that you have to be contract compliant. Obviously, if you don't have your staffing complementable, you're not contract compliant. We worked with every one of our providers to say that we don't want that money back. We would rather that you invest it in things that increase recruitment and retention initiatives. So we have roughly 330 individual programs across the state. 228 of them had surplus this past year. So that was SFY 22. It's about 69% of our provider network. And the total amount of surplus was about 13.9 million.
And relative to that, because we're hearing from private providers across every state agency. And most of your services are, let me ask a question, not a statement. Are most of your providers private providers? Are most of your services delivered by private providers?
Right, yeah, DCF only delivers the direct service in Solnits.
Right.
So all of our services are contracted.
And I think that that's something that many people don't realize, that most state services that are direct care state services are not provided by the state any longer. We regulate those services or oversee those services, but we don't provide those services by and large.
That's right.
So thank you for that. I just wanted to make sure. Representative Walker.
Thank you. A couple of things I want to follow up. So you're saying you have 330 providers.
100 provider organizations, 330 programs that those providers provide.
Okay, so those 330 programs, and you have 100. You said
We have 100 provider organizations.
Okay.
And across the board, those 100 provider organizations run 330 programs across the state.
Okay, all right. And of those, almost 2/3 of them are not compliant with what the contract calls for them to do.
As far as staffing,
Right.
but we're also in the middle of a national staffing crisis, so we did not held them harmless to that.
In those contracts, are there other qualifications that your organizations have to meet in order to be compliant?
Yes. so
Could you
there-
bring that to the
Absolutely.
working group? We'd like to see. I think one of the things we'd like to know is how are you evaluating quality assurance with your providers then in that area. And I want to go back to a couple of things that Representative Gilchrist talked about trafficking. I'd like to know what programs you have for kids that have been trafficked, because I've heard some circumstances where they ended up getting arrested because we didn't have anything for them so that we could get them into another group. I'd like to know how many programs we have and are they filled?
Yeah.
Do we need to have more? I think that's something that, because the last thing, these are kids who are being pushed into something. They're being pimped. And as far as Representative Datham, I'd like to know about the trends that she was asking. You were on what I was glad she was going up, because it also helps us to understand the population and the needs, because if if 90% of them are from TFA families or SOG families, then we know that a lot of this is poverty driven. So we can zero in on that a little bit more. And then when you said that you looked at the trends for the managed congregate care, and the reason that's why you moved them, we'd like to see the data that you used to zero in on that result that you felt because of what was going on with your clients, you felt that this pushed you into a reduction, and why it was a reduction in that.
I'd certainly do that.
And see, the foster care, I'm really concerned about the foster care because I'd like to know the number of family, I'm hearing from families that's saying that they're dropping out because of this, and this. So I need to know what are our foster care families trends are right now,
Okay.
and how are we supporting them?
Mhm.
Because a lot of, I've heard some kids that have gotten into JJ have come from foster care families.
Mhm.
So we've got to find out, I'd like to know how many of that are making those transitions also. Let's see, did I get all the ones that I was listening to everybody's questions and I wanted to, the congregate care, the moving away from comprehensive residential treatment services. Why did you guys do that? And I guess for placement disruption, can you share the data with us on placement disruption? That's something else that we're hearing from families and everything. And could it be broken down by what types of services there's placement disruption? I think that's it. I know we're gonna have a book from you. But it helps us.
It
And then-
helps tell the story. We
Yeah.
definitely will provide you with any information we can to really
and-
create a full picture.
I know we're speaking to the choir and everything, but we give you the opening, but you can always talk to us later or something. But if there are some funding issues that need to be addressed, we need to know that. Or maybe we'll stumble into it with the data that we get to say this needs to have help. So,
We fully support the governor's budget.
okay, yes, you did. You said that. Okay, I got it. Thank you.
Thank you, Representative Nuccio.
Thank you for the second round. What you were saying there kind of piqued my interest. This is my first time really kind of sinking into the abyss of the budget. So it is not- I don't know how y'all sleep at night.
We don't.
We
That's
don't.
the problem. We don't.
I'm sending text at 4 o'clock in the morning. What the hell is that? So I'm going through this here and you guys have 2,649 employees. But then from what you were just saying, we have 100 different provider organizations providing all of these services. So can you give me an idea? What are the employees that you have doing in contrast to the programs that you say are being run by other organizations?
Oh, certainly. Yeah. So
That's
the,
probably like a basic 101.
yeah. So the lion's share of caseload carrying social worker provides case management. So that worker would be providing the assessment and analysis of what it is that a family needs when they come to our attention. And then they would be working with our provider organization to deliver that. So an example might be a person who might need increased capacity in their parenting skills. So that caseload carrying social worker would refer the family to a parenting service. And then the case manager or the social worker within the department would work in conjunction with that provider to find out the progress and whether or not the issue that, they came to our attention has been addressed. So there's various service types to address the needs of families that come to our attention, whether it's substance use, parenting capacity, intimate partner violence, and a whole host of things that you would refer into community to have serviced.
So they're basically coordinating the care.
They certainly are.
Okay. And then looking at your budget, then are all of these, the 100+ provider organizations, is that the stuff that's in like other than payments to local governments? Or is that in that's obviously where the largest dollars are in your budget here?
It is, yes, go ahead.
So if you look at all of our accounts, with the exception of personal services and other expenses, every other account that we have is provider driven.
Okay.
So all of our contracts are funded out of all of those other accounts.
All right, so those 100 programs are broken up into those breakdowns that are listed here in the budget.
One caveat, board and care, foster, congregate, and adoption. Those are actually our own costs. Those are very minimally funded for providers. Everything else is provider funded.
So those are our own costs, so the costs of that child's expense, so that's the.
Foster
paid to-
care.
pays for the
Mhm,
stipend,
mhm,
they don't get
mhm.
them for us. Okay, all right, that's all I have, thank you very much.
Thank you, Representative Johnson.
Thank you so much, Madam Chair, and thank you for your testimony. I was listening on the way in. But I do have a question about the children who are in families that may be homeless, but also some of the homeless shelters don't take adolescent and teenage children without some type of supervision, depending on what the homeless shelter situation is like in that particular area. How is that being addressed through, do you get those cases and is that something that you're finding a placement for
Mhm.
adolescents in those circumstances?
So if teenagers are committed to the department at 18, they can choose to stay on and receive services post-majority up to the age of 23 currently. And so we have about 360 children that are over the age of 18 that we currently support in higher ed or vocational programs. So typically, children that might find themselves in a situation of homelessness may look to reenter if they have exited care at 18. And we have a whole reentry process that we could talk about if you'd like.
I would really appreciate a lot of information on that, just so I can look at it in terms of your budget and maybe where additional needs might be. Thank you so much. Thank you, Madam Chair.
Thank you. Any other questions? Representative Porter.
Hello.
Thank you, Madam Chair. Hello, Commissioner and
Hello,
team.
Porter.
Great to see you guys. First, let me just say thank you for the wonderful work that you guys do.
Thank you.
Really proud of this agency. I've been in judice, so some of these questions may have been answered, but I wanted to ask you about the ICAPs. What other services have waiting lists, or what is the average waiting time for the behavioral health services with DCF?
We can get you a breakdown of all of our waiting lists, but specific to ICAPS, you want to talk about the increase?
So ICAPS is not directly funded or contracted through DCF. It is Medicaid funded under DSS.
Okay.
And they just completed, I believe it was last month or the month before, a rate increase to the ICAPS providers that we're hopeful will 15%, which I'm hopeful will impact our waiting lists, but we can get those numbers specifically for you.
So 15 or 50?
15.
15.
Oh, I thought I heard 50.
That's why you chimed.
Thank you.
15.
Thank you. And that would be great if you could get that information for the working group. And then with the crisis that we have, question is, why does the governor's budget reduce funding for DCF out-of-home treatment programs? The budget says it's a baseline adjustment. What does that mean in terms of the availability of the service for kids? And then can you provide a detailed list of all of the reductions included in that particular adjustment?
These were directly related to our reduction of children in care, but we can get you the specifics for the working group.
Okay, and am I at my limit or do I have?
Keep going.
I don't want to get dragged out of here. Brett Walker said, don't put me in that mix, leave me out of that. Okay, so another question, can you explain why utilization of these services might be low
Mhm.
when we're looking at that? And what has changed to make the department no longer need $16.5 million, especially as we hear from children and families in need?
Certainly. And, I appreciate the opportunity to talk about trends in child protection. I strongly believe that the way to get help for kids and families is to not bring kids into foster care, particularly if a family is struggling with poverty. We have to invest in our community-based services and not necessarily believe that bringing a child into care and separating them from their family is the way to address a family need. That being said, the reduction of children in care has been about, I'm not sure if you heard this while you were in the other committee, it's been about 30%. And really looking at whether or not a child has to come into care or can remain safely at home. And so the capacity in those programs is directly related to the number of kids that we have in care. at the same time, we're building up our prevention infrastructure to do more of an upstream approach to see what is it that can be put in place to help particular families so they don't become, so their child doesn't become a candidate for foster care, and really realizing the true tenets of family first to try to stabilize children at home versus coming into foster care. So that's the short answer to why you're seeing that shift, but we can provide you with the details to kind of fill in the blanks.
And I am absolutely in support of that. I mean, if we can keep kids with families, that's really important. Kind of good segue into the next 10.1 million of that reduction adjustment is in foster care. So can you speak to that? The state seems to be struggling to attract foster families, right? And then we're reducing it, especially those willing to take the kids with behavioral health needs, which we know we're seeing an uptick in that, especially coming out of this pandemic. So can you just explain why those proposed reductions and adjustments?
Similar to that in terms of the number of kids that are in care, we just recently did an overhaul of our therapeutic foster care model, which had not been redesigned in over 20 years. So we can give you a little bit of information as it relates to that. Something else, I lost my train of thought. Anything else on foster care reduction? Oh, and I also think that it's also related to our emphasis on kinship care and the fact that 50% of the kids that we have in care under the age of 18 are with relatives or someone that they know. Our relatives in Connecticut are compensated just as our core families are. So, any changes or shifts in our foster care population are reflective of our emphasis on kinship care and our overall reduction of kids coming into care and our therapeutic foster care redesign.
Okay, and you said the kinship is 50%?
Of kids under the age of 18.
Okay, and what has that reduction look like if we take a, I don't know, 5-year window, looking at how you've been able to make that reduction, keep kids in families or through kinship?
Our aspirational target is to have 70% of our kids with their relatives, but again, that's aspirational.
Okay. And then I want to talk about the ARPA funding. What is the department's plan to continue the vital work without that ARPA support? Because you guys have been able to do some really great things, creative things around that funding.
We were very thoughtful in our behavioral health initiatives that came from ARPA funding, that we wanted to make sure that they would be sustainable once the temporary funding was no longer available to us. And so things like scaling up mobile crisis, again, it wasn't a new service. It was something that we were able to scale up and looking to see which of these services would be able to be picked up by Medicaid. Things like our urban trauma initiative, rather than using the money to pay a provider to deliver the service, we paid the provider to train other providers to do it. So it was kind of a train the trainer model. So once that money is done, those other, we've increased our capacity by all of the providers that are delivering that particular clinical model. So we were trying to be really thoughtful when we thought about the ARPA initiatives of which could be picked up by Medicaid and which would only need that one-time seed to kind of sustain themselves.
Okay, so that's you're headed in the right direction. Can you provide a detailed list of all the ARPA funded services and then how or whether each one will continue with or without the ARPA funding? I think that will be helpful.
We certainly can.
And I think I'm done. Thank you again for being before us today. And thank you, Madam Chair.
Thank you. One more question on private providers.
Okay.
We're having a debate here on private providers. And you said 228 people were non-compliant for staffing reasons. The other parts of the contract they were compliant in, and those 228, because of the staff shortage, you held those providers, you held them harmless. But I'm trying to get to the point where all of the provider money comes from the state, and whether it comes from DCF or DSS or DDS comes from the state. And a couple of years ago, we put some money in to try to raise the rates for providers. In your contracts, do you lay out what the bottom rate is that an employee has to be paid in those services, but not only for the bottom rate, do you have different rates? So for example, if someone is an RN, do you provide say to somebody, you have to pay X number of dollars for the different categories or job classifications that provider has?
No, we do not. We let them determine their pay scales. When we go out to bid for a newly designed service, we obviously, we say what each provider, each region is going to get for funding. We use our own estimates on, we're requiring an RN in this program, we're requiring an LCSW in this program. Here are the promulgated average salaries for these folks. So the money that's going out to bid for the provider to bid on is inclusive of that, and we share that with providers, but they can make the decisions independently as independent organizations on what they pay their staff.
So the average salary, so across the state, I'll use a 24/7 operation like the Department of Corrections. They have RNs within the registered nurses within the Department of Corrections. And they're saying that the rates that the state is saying that they're going to pay somebody is so low that they can't get anybody to come in. Are you, in your calculation, when you're putting out the service for that provider, are you using rates that the state is promulgating for their own services? Are you actually using rates that are being paid to people in the atmosphere of
We're using general public rates.
you're using general public rates? Because we're finding that if an RN, for example, a registered nurse, the Department of Corrections is paying $50 an hour, but at a hospital, they're getting paid $75 an hour. So no one is going to want to work for the Department of Correction because they're getting paid $25 an hour more in a private system. I'm trying to figure out, because we have a bad habit of not providing financial resources to providers to do the jobs that we expect them to do. And I just want to know, is that something that you think is happening within the services that you're asking them to do? I'm trying to get to the
I think we hear you understand the question. You know, one of the analysis that we did do was an average nurse's salary was about 88,500. Travel nurses in February of 2023 was about 103,000. But state nurse salary starts at the 76,000 range. So, you know, when you talk about working for the state in that particular job class, you know, they did some adjustments to the nursing salary as it relates to what nurses make in the general public. The provider community and who they have to hire in terms of their clinicians or their BS, you know, bachelor's level service home visitors per se, that number comes from what the average of that particular salary would be in the general field.
But you can only give out the dollars that we give you.
Right.
So if
Right.
I give you $100,000 to do a job, and that job out in the general population would cost $130,000. You're saying to the provider, I want you to do X. I'm only going to give you $100,000. We know it costs 130, but I'm only going to give you $100,000. Are we setting that provider up for failure?
Yes.
Thank you. That's all I have.
Wait.
Can
Representative Tucker.
I caveat that though?
Yeah.
And please do.
So we do work very closely with our providers, and in some cases, we have made service adjustments to try to give them the increases to salaries that they need. At this time, I do believe that our providers have the resources to hire who they need to hire.
Okay.
I just want, the other part of this, are the Medicaid rates that we pay through Medicaid reimbursement, are those established in these contracts so that if I have a nurse and I want to pay the nurse because I know I can get a nurse for, let's say, $100,000 because I'm in trouble. We're capped by Medicaid rates for personnel. Is that,
Not in our private provider contracts. That's certainly a decision point within the provider organization, but it is not a contract requirement.
but we do use Medicaid dollars to pay for some of the providers if it's
Reimbursable.
reimbursable.
Some of our services are Medicaid reimbursable.
Yeah, and so because of that, does Medicaid provide us with a range for what we can pay? Because of what our Medicaid plan allows us to do.
It is what the provider can bill for. That is not necessarily the cap that they have to have on their salaries. It's just what they'll.
Okay, I
get
don't
reimbursed.
understand that. Wait a
So,
minute.
so the provider in a Medicaid eligible program would bill Medicaid. They might decide to pay higher than what Medicaid will reimburse, which they can do. We don't cap that.
So, no, you don't cap it, but Medicaid does. And that's
Medicaid
our
will cap the
Medicaid plan
reimbursement,
that does that
yes.
restriction. So whatever we are allowed to bill on Medicaid is our ceiling.
If the provider wants to break even, yes.
And please understand, we realize that this is not, you're not unique.
We're not Medicaid.
You're not unique. DSS, DCF, DDS, everybody has the same restrictions with their providers. And so I think the question that I'd like to know is how many of our providers that we have of the 330 that you, or 100, I got confused with the numbers. Anyhow, of those providers that you have, how many of them are billing Medicaid versus being able to do it on their own? Because you do have a lot of Medicaid funding. When I look at the sheets from DSS on our Medicaid plan, you do a lot of funding in that. So that, I think, is more of what, okay, we figured it out. Thank you. But I'd still like to know.
Mhm.
Thank you.
Can get you that.
Representative Exum.
Yes, thank you, Madam Chair. I have a question around ICAPS, around the fact that the Medicaid funding is under DDS, and I know that you just completed a rate increase of 15%. I also know this is a really sought after program. And so I'm wondering what other strategies or coordinated efforts are there with DDS beyond that 15% rate increase? Because I know that there is such a long waiting list for this program, and there are parts of the state that really don't have any providers. So I'm just wondering if there's any more that you could provide around that ICAPS.
Yeah, I
piece.
think that, that speaks to the other issue we were talking about the full service continuum for children's behavioral health. I think the over reliance on ICAPS is because there was nothing else. And so really making sure that we fill out, the extended day treatment, outpatient services for kids, all of the other service types that would also fill in the children's behavioral health continuum. People have had some success with ICAP, so it feels right to kind of continue to go back to. But I truly believe as we build out the continuum of our children's behavioral health services, we'll see less of a reliance on that one particular service type and more matching to the needs of where that particular child and family are. But, DCF, DSS, even DDS and DMIS, we're all around the table as we talk about adjustments to the children's behavioral health continuum. And we, within DCF, have actually carved out a whole division to address the children's behavioral health community-based needs to be elevated to a level that reports directly to one of my deputies to really, think about our children's behavioral health continuum for the long haul.
I think the continuum is the point. I
Yeah.
think it's really important. I also think ICAPS in particular may be such an effective program for many
Mhm.
because it does go into the home. It's a long time. It's evidence-based. If it's ICAPS itself versus, which there are some other programs that mimic it that are also very good. But I think that also is something to look at trend-wise. Are families looking to have that service delivered in the home more? It makes me wonder when you have a list as extensive as this one.
It's interesting that you asked that question because what we also have noted is that along with the trend of in-home services for families, we see fewer people in the human services workforce who want to do that. I think the pandemic showed that there are opportunities to be able to deliver clinical services, whether it be telehealth or in some other modality, and that's where we saw like a big shift that people don't want to go into homes anymore. So I do think that as we, I was just on a call with some of our academic partners. Someone mentioned about, really thinking about that feeder and the pool of who's developing this next generation of social workers and what that looks like. And so I think you're hitting the nail on the head in terms of really balancing the needs of families and how they receive services with what we can produce in the workforce, whether it's in the public agency that's managing, assessments and the cases, or it's the service providers who are actually delivering services in community and in family.
I think that's really interesting that more people want them in and less people want to go in. So there's that tension, and that's what you're seeing. Yeah, that's really interesting. Thank you so much.
Thank you for the questions.
I just want to follow up a little bit more.
Oh, cool.
So do we, for kinship care, do we have a floor and ceiling amount that we pay for families for kinship care?
We do. We pay our kinship families the same as our core foster homes.
As your what?
Our core foster homes. And then if there is a kinship provider that is providing therapeutic foster care, it's at the therapeutic rate.
Okay, could we get those, have those rates increased at all over the last 5 years?
We can show you the trends on that at the
Yeah.
working group.
We'd like to see that. Thank you.
All right.
Any other questions? Seeing none. Representative Porter.
I'm sorry. I was trying to be done, but it seemed like we on a roll. Just to go back to the private residential treatment facilities, when we look at the budget, both are proposed to have their statutory rate increase frozen. And that's resulting in a cut to the current services, the private residential treatment facilities. So PRTF.
We're going to bring that to the
Working group.
Okay, because I know it's also provided a rate increase, but the funding amounts actually end up canceling out if I'm not mistaken. So can you explain the rate change proposed for that? 'Cause
Certainly
I think
can.
that's really important. And then the other thing that I forgot when we were talking was, other than the reduction in the utilization of out-of-home services and national best practices, can you point to outcomes for the kids that show improvements, right? For the kids and how their well-being and what those with the reductions.
So
like what's been the impact of that?
One of the indicators for a reduction in children in placement is whether or not there are higher incidences of repeat maltreatment or, coming back to the attention of the child welfare agency, or re-entry into care with that older youth that has left care and then comes back in because they're not stabilized on their own. And so we fall well below the national average in both those indicators, and watch it really closely to make sure that there's not this revolving door in and out of foster care. Having said that, I think that it is also important to recognize that, we have infused our equity work in everything that we do. And, when you see the disparity of children of color in care, and recognizing that some of the factors that relate to why children come into care and why families are involved with us, sometimes it's just based on, who they are and characteristics of that particular family. And that's not fair. And so for us, our equity work is tied to outcomes. And so about 10 years ago, for instance, a Black child was about 4.13 times more likely to come into care in Connecticut. Today, that number is about 2.5. And so a reduction in disparity also recognizes whether or not the child should have been in care in the first place. So, I think our attention to, equity, as well as our attention to relatives, our attention to prevention, and our attention to really recognizing when child maltreatment occurs, there is a need for foster care to be there, but, really trying to make sure that our full service continuum is reflective of what children need and not just a default to foster care.
Yes, thank you so much for that. And thank you for the reduction. That's almost half.
Almost.
What you're talking. And I was reading something yesterday, you just jarred my memory. Some folks that work intimately with the agency and just saying the difference that they've seen with DCF and the way DCF is handling families and children and how people used to be afraid, you know, like to have DCF involvement because it meant, you know, kids were leaving home. So the fact that you guys are turning that around and really, really, really talking about equity and not just talking about it, but there's a manifestation of it in your data. So I just really want to thank you again for that. Appreciate that. Yes. You too, Michael.
All set, guys? Thank you, Commissioner. Appreciate it. Have a nice day.
We'll be back.
Like I said before, if you would like to watch the 117 people that are coming to,
173.
I only have 17.
Let me see, maybe.
I have-
Once-
I'm miss-
It's 173.
well, I'm missing a whole lot.
Well, we start at noon, right?
We start at 12:30. Yeah, look, this is.
Sorry.
Taylor gave you the right one and gave me the wrong one.
I'm sorry, I can't help you out with that.
I didn't even get one. What are you complaining about? It's about 9 hours.
Okay.